Welcome to our comprehensive guide on arterial blood gas, ABG, interpretation. In this video, we'll explore how to determine if ABG values are within normal ranges, identify primary and mixed acid-base disorders, assess compensation, and uncover the mechanisms behind hypoxemia. Understanding ABG is crucial for evaluating a patient's respiratory and metabolic status, and for making informed clinical decisions. We'll start by outlining the objectives you should achieve by the end of this chapter, then dive into the background of ABG analysis, and gradually build up to advanced interpretation techniques. Let's begin our journey into the world of acid-base balance and oxygenation. The main objectives of ABG analysis are to determine whether arterial blood gas values fall within normal ranges, identify primary acid-base disturbances and mixed disorders, assess compensation, and evaluate the mechanisms contributing to hypoxemia. By mastering these skills, you'll be able to interpret ABG results with confidence, recognize critical changes in a patient's status, and guide appropriate interventions. These objectives form the foundation for understanding the clinical significance of ABG values and their impact on patient care. Arterial blood pH and PaO2 must be maintained within narrow physiologic ranges to ensure proper function of enzymes, cells, and organs. ABG samples provide key information about acid-base status and oxygen, carbon dioxide levels. The bicarbonate buffer system is central to maintaining acid-base balance, and its chemical constituents reflect the function of other blood buffers and the kidneys. Understanding the background of ABG analysis is essential for interpreting results and recognizing the interplay between respiratory and metabolic processes. The bicarbonate buffer system is the main blood buffer, crucial for maintaining acid-base equilibrium. The reaction involves hydrogen ions, bicarbonate, carbonic acid, water, and carbon dioxide. The law of conservation of matter ensures equilibrium between reactants and products. This principle is reflected in the equation relating H-, HCO3, menin, and H2CO3, which can be transformed into the Henderson-Hasselbalch equation. This equation forms the basis for understanding how changes in one component affect the others, and is fundamental for ABG interpretation. The Henderson-Hasselbalch equation is a cornerstone of acid-base interpretation. It mathematically relates arterial blood pH to bicarbonate and carbon dioxide levels. By understanding this relationship, clinicians can predict how changes in HCO3 menin or PaCO2 will affect pH and vice versa. This equation is derived from basic chemistry principles and is essential for identifying primary acid-base disorders and evaluating compensation. When interpreting ABG results, focus on three main components: arterial blood pH, bicarbonate HCO 3-miniv, and carbon dioxide PaCO2. These values are interconnected, and changes in one often lead to compensatory changes in the others. Oxygenation, assessed by PaO2, should be examined separately after evaluating the acid-base relationship. This approach helps identify primary disorders and guides further investigation. There are four primary acid-base disorders: respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. Acidosis and alkalosis refer to processes that produce acid or base, while acidemia and alkalemia describe the state of the blood. Respiratory disorders originate from the respiratory system, while metabolic disorders arise from various sources, including the gastrointestinal system and kidneys. Understanding these primary disorders is key to accurate ABG interpretation. Respiratory acidosis is caused by retention of CO2 due to decreased alveolar ventilation, leading to increased acid production. Respiratory alkalosis results from blowing off CO2 through increased ventilation, reducing arterial blood acid. These disorders can be acute or chronic, and their identification is crucial for determining the underlying cause and guiding treatment. Metabolic acidosis occurs when acid increases in the blood, either by ingestion, production, or loss of bicarbonate. Examples include diabetic ketoacidosis and lactic acidosis. Metabolic alkalosis arises from excessive loss of acids or excessive intake or retention of bases, such as overzealous sodium bicarbonate infusion or vomiting. Recognizing these metabolic disorders is essential for ABG interpretation and clinical management. Mixed acid-base disorders occur when two or more primary disorders are present simultaneously. These can include combinations of respiratory and metabolic acidosis or alkalosis, as well as triple disorders involving both metabolic and respiratory components. Identifying mixed disorders requires careful analysis of ABG values and recognition of patterns that do not fit single primary disorders. Normal ranges for arterial blood gas values are essential for interpretation. The normal pH is 7.36 to 7.44, with a mean of 7.4. PaCO 2 ranges from 35 to 45 mm Hg. HCO 3 mins from 23 to 27 mins count. L and PaCO 2 from 80 to 100 mm Hg. Base excess ranges from -4 to +4. Knowing these values helps identify deviations and guide further analysis. The partial pressure of oxygen changes as air moves from the environment to the arterial blood. Ambient air contains 21% oxygen, resulting in a partial pressure of about 160 mm/H. Hydration in the trachea reduces this to 150 mmHg. And mixing with CO2 in the alveoli further decreases it to about 110 mmHg. Understanding these changes helps explain normal and abnormal oxygenation. Compensation for acid-base disturbances occurs through three main mechanisms: buffers in body fluids, the respiratory system, and the kidneys. Buffers act almost immediately. The respiratory system can modify acid-base balance within minutes, and the kidneys provide long-term buffering over hours to days. Understanding these mechanisms is crucial for interpreting ABG results and assessing compensation. There are three main buffer systems in body fluids: the bicarbonate buffer, phosphate buffer, and protein buffer. The bicarbonate buffer is chemically weak but physiologically effective because its components can be modified by the respiratory system and kidneys. The phosphate buffer is effective near the blood pH and is abundant intracellularly. Proteins are the most plentiful buffer in body fluids. The respiratory system compensates for acid-base disturbances by retaining or blowing off CO2. Retention of CO2 increases H-MICE, shifting the equilibrium toward acidosis. Blowing off CO2 eliminates excess H-MICE, helping to correct acidosis. This mechanism begins within minutes and is effective in individuals with healthy respiratory systems. The kidneys compensate for acid-base disturbances by eliminating or retaining H-MICE and HCO3-minin. This mechanism provides effective long-term buffering but takes hours to days to complete. Renal compensation is essential for maintaining acid-base balance, especially in chronic disorders. Metabolic alkalosis can be chloride-responsive or unresponsive. Chloride-responsive causes include vomiting, nasogastric suction, chloride-wasting diarrhea, villus adenoma, diuretic therapy, post-hypercapnia, and certain drugs. Chloride-unresponsive causes involve adrenal disorders, Cushing syndrome, exogenous steroids, and licorice ingestion. Understanding these causes helps identify the underlying mechanism. Respiratory alkalosis can result from anxiety, hypoxia, CNS disorders, ventilator-induced hyperventilation, pregnancy, infection, pulmonary edema, lung disease, salicylate toxicity, catecholamines, and other factors. Recognizing these causes is important for diagnosing and managing respiratory alkalosis. Metabolic acidosis can be caused by elevated anion gap or normal anion gap conditions. Elevated anion gap causes include renal failure, ketoacidosis, starvation, diabetes mellitus, alcohol, lactic acidosis, and toxins like methanol and ethylene glycol. Normal anion gap causes include hypokalemic acidosis, renal tubular acidosis, diarrhea, and buffer deficiencies. Respiratory acidosis can result from CNS, depression, impaired lung motion, sedatives, pleural effusion, pneumothorax, acute or chronic lung disease, neuromuscular disorders, aspiration, tumors, and chronic obstructive diseases. Severe pneumonia or pulmonary edema can also contribute. Identifying the cause is crucial for effective management. The anion gap is a useful tool for detecting mixed acid-base disorders and guiding therapy. It is calculated as Na-, Cl-menons, HCO3-menons. An elevated anion gap indicates the presence of added acids, such as in renal failure or ketoacidosis. Understanding the anion gap helps refine ABG diagnoses and identify complex disorders. Compensation patterns differ for each primary disorder. In respiratory acidosis, PACO2 increases, and compensation involves decreasing H- or increasing HCO3-menon. Respiratory alkalosis features decreased PaCO2, with compensation by increasing H- and decreasing HCO3-menon. Metabolic acidosis involves increased H- or decreased HCO3-menos, compensated by decreased PaCO2. Metabolic alkalosis shows decreased H- or increased HCO3-menos, compensated by increased PaCO2. Hypoxemia is defined as decreased oxygen levels in arterial blood. The main causes include alveolar hypoventilation, diffusion impairment, shunt, and ventilation-perfusion mismatch. A fifth cause, decreased inspired oxygen concentration, is relevant at high altitudes or during flights. Recognizing these mechanisms is essential for diagnosing and managing hypoxemia. A systematic approach to ABG interpretation involves identifying whether each parameter is within the normal range, determining the primary process and compensation, and refining the diagnosis. Start by checking pH, then PaCO2, HCO3-menons, and finally PaO2. Compare directional changes to known patterns for primary disorders and use rules of thumb to assess compensation and mixed disorders. Two key rules of thumb help refine ABG diagnoses. First, in acute respiratory alkalosis, a decrease in PaCO2 of 10 mmHg results in HCO3 mm decreasing by 2 mmL. If the change in HCO3-menon is greater, compensation has occurred. Second, to differentiate acute from chronic respiratory acidosis, HCO3-menon greater than 30 MEq. L suggests chronicity. These rules guide interpretation and help identify compensation. Hypoventilation is a major mechanism for hypoxemia. If hypoventilation is the cause, PaO2 should decrease by 1 mmHg for every 1 mmHg increase in PaCO2. If PaO2 decreases more, other causes such as ventilation-perfusion mismatch, shunt, or diffusion impairment may be present. This rule helps distinguish between simple hypoventilation and complex lung pathology. Two important points to consider. First, compensation for metabolic acidosis and alkalosis should occur quickly via respiratory changes. PaCO2 should move in the same direction as pH. If compensation has occurred, PaCO2 should approximate the two numbers to the right of the decimal in pH. For example, pH 7.3, PaCO2 30. Second, physiological compensation rarely returns pH to normal except in respiratory alkalosis. If pH is normal and one disorder is identified, look for another. SaO2 is the percentage of hemoglobin fully bound to oxygen, measured from arterial blood. Pulse oximetry estimates SaO2 as SpO2, but SpO2 does not equal PaO2. This distinction is critical, as confusing the two can lead to serious errors in patient management. Always interpret SaO2 and PaO2 separately, and use the oxygen-dissociation curve to understand their relationship. The oxygen-dissociation curve plots PaO2 against SaO2, illustrating how hemoglobin saturation changes with oxygen partial pressure. At normal body temperature and pH, specific values of SaO2 correspond to particular PaO2 levels. This curve is essential for understanding oxygen delivery and for avoiding errors in interpreting oximetry and ABG results. ABG values can be categorized as acceptable, poor, or very poor. Acceptable values include pH 7.4, PaCO 240 mm Hg, HCO 3 mm 25 MEq, L, and SpO2 95%. Poor values are pH 7.2, PaCO 260, mm Hg, HCO 3, Minno 15, MEq L, SpO2, 90%. Very poor values are pH 7, PaCO 280, mm Hg, HCO 3, Minno 5, MEq L, SpO2, 85%. Rapid deterioration is more serious than gradual changes. Interpreting ABG values requires a systematic approach, knowledge of normal ranges, understanding of primary and mixed disorders, and recognition of compensation mechanisms. By applying rules of thumb and considering clinical context, you can accurately diagnose acid-base disturbances and hypoxemia. Always interpret SaO2 and PaO2 separately and use the oxygen-dissociation curve for guidance. Applying ABG interpretation in clinical practice involves integrating laboratory values with patient symptoms and history. Rapid identification of acid-base disturbances and hypoxemia can guide urgent interventions and improve outcomes. Always consider the rate of change in ABG values, as rapid deterioration is more dangerous than gradual shifts. Let's look at a case of respiratory acidosis. A patient presents with decreased alveolar ventilation, elevated PaCO2, and low pH. Compensation may involve increased HCO3 menin. Identifying the cause, such as CNS, depression, or lung disease, is crucial for treatment. Use the rules of thumb to assess compensation and differentiate acute from chronic cases. In metabolic acidosis, a patient may have low HCO3 menin and low pH. Compensation involves decreased PaCO2 through increased ventilation. Causes include diabetic ketoacidosis, lactic acidosis, or renal failure. Assess the anion gap to distinguish between elevated and normal gap acidosis and identify mixed disorders if present. Mixed acid-base disorders can be challenging. For example, a patient may have both metabolic acidosis and respiratory alkalosis, with low pH, low HCO3 menins, and low PaCO2. Careful analysis of ABG values in clinical context is needed to identify all components and guide treatment. A patient with hypoxemia may present with low PaO2. Assess whether hypoventilation, diffusion impairment, shunt, or ventilation-perfusion mismatch is the cause. Use the rule of thumb relating PaO2 and PaCO2 to distinguish simple hypoventilation from other mechanisms. Metabolic alkalosis may present with high HCO3 menin and high pH. Compensation involves increased PaCO2, Causes include vomiting, diuretics, or adrenal disorders. Assess chloride responsiveness and identify underlying mechanisms for targeted treatment. Respiratory alkalosis features low PaCO2 and high pH. Compensation involves decreased HCO3 menoms. Causes include anxiety, hypoxia, CNS disorders, and drug-induced hyperventilation. Identify the cause and assess for acute or chronic compensation. Triple disorders involve combinations of metabolic acidosis, metabolic alkalosis, and respiratory acidosis or alkalosis. These cases are rare but require careful analysis of ABG values and clinical context. Look for patterns that do not fit single or mixed disorders and use the anion gap and compensation rules for guidance. Let's review the key concepts covered in this video. ABG interpretation involves understanding normal ranges, primary and mixed disorders, compensation mechanisms, and the importance of SaO2 and PaO2. Use systematic approaches, rules of thumb, and clinical context to guide diagnosis and management. Here are some practical tips for ABG interpretation. Always check normal ranges first. Identify the primary disorder, assess compensation, and look for mixed disorders. Use the anion gap and rules of thumb to refine your diagnosis. Remember, rapid deterioration in ABG values is more serious than gradual changes. Common pitfalls in ABG interpretation include confusing SaO2 with PaO2, overlooking mixed disorders, and failing to assess compensation. Always use the oxygen-dissociation curve to relate SaO2 and PaO2 and apply systematic approaches to avoid errors. Clinical context is essential for accurate diagnosis. Advanced ABG interpretation involves integrating laboratory values with clinical findings using the anion gap, compensation rules, and oxygen dissociation curve. Recognize complex patterns and triple disorders, and always consider the rate of change in ABG values. This approach ensures accurate diagnosis and effective management. In summary, ABG interpretation is a vital skill for clinicians. By understanding normal ranges, primary and mixed disorders, compensation mechanisms, and the relationship between SaO2 and PaO2, you can make informed decisions and improve patient outcomes. Use systematic approaches, rules of thumb, and clinical context for accurate diagnosis. Thank you for joining us on this journey through arterial blood gas interpretation. With these concepts and techniques, you're equipped to analyze ABG values, identify acid-base disorders, assess compensation, and manage hypoxemia. Continue practicing and applying these skills in clinical scenarios to enhance your expertise and patient care.